Good morning from all around the world, and thank you to Structural Heart Life Cases, broadcasting directly from the cardiac catheterization at the Mount Sinai Heart Hospital in New York City. My name is Pedro Moreno. I will be your moderator today. Remember, we want this to be an interactive experience. Please send us all your questions on the website or on YouTube. And you can review all our cases, previous cases, in our website at ccclivecases.org. Let me transfer you now to the team. We have a very interesting case.
All right, good morning, Pedro and our audience of our structural heart live cases. We continue to show some interesting case. And today is the step by step we show implantation of valve-in-valve TMVR. And then I'll talk about various recent data on the TMVR field. Just to introduce everyone here, my left side is Dr. Keeney, then Dr. Gilbert Tang, Dr. Parasuram, our structural, and then we have all our three structural heart failure fellows, which we have at present. So all of them, everybody is present in the room besides the rest of the staff, and of course Laracus on echo, and Dr. Montgomery as a chief anesthetist. With that note, we'll start our presentation. This is our support. Basically, what happened here? Guys, it's not moving. Okay. So this is various people which we have put in here. Then mitral valve-in-valve replacement using SAPIEN-3 Resilia for failed Carpentier Edwards Pericardial surgical valve. So this basically is the case today. And so somehow we're having a trouble in advancing the slides today. I know it's a cold weather. It's a 66-year-old. This patient actually has a long-standing history of rheumatic MRMS as a bio-prosthetic valve and MAGE procedure, which was done back in 2008. And since then has done well, and now developed some both stenosis and regurgitation with the leg edema, and AFib has been on Apixaban, got ablation, coronaries are normal, and recent echo showed abnormal mitral prosthesis, mainly stenosis with a moderate MR and mild AI and moderate TR, and moderate pulmonary hypertension, mild AI. So what happened is, because of the significant mitral valve degeneration at a young age, of the patient being 64, patient was referred for surgical mitral valve re-op. And basically during the induction, patient developed severe hypotension and developed a severe pulmonary hypertensive crisis. Though the procedure was aborted, patient was recovered in the recovery ICU, and then felt that it's not a surgical case and tried to do with the TMVR. So valve-in-valve TMVR was the goal, and with that note, we can go to the echo team. This is the old echo, which showed both degeneration in terms of stenosis and regurgitation. So we can talk about our, maybe live echo should be the better way.
Yes. Thank you, Dr. Sharma. Good morning. From New York, this is deep gastric images, normal LV function. This is the long axis of the LV gastric images, again, very supranormal LV. This is the right ventricle, as you can see, dilated and at least moderate to severe hypokinesis.
Show me my
this is the left atrial appendage, is clean.
Bring the key.
This is the aortic valve, and as you can see, with a mild aortic regurgitation.
I changed Montgomery.
Mild to moderate tricuspid regurgitation with a mild pulmonary hypertension, about 40 systolic PA pressure, at least by echo. And this is the mitral valve, the bio-prosthetic mitral valve. As you can see, FLEL, one of the leaflets of the prosthesis, very beautiful image, and severe MR. Actually, you know, yesterday we did a transthoracic echo, and that's why if you suspect mitral valve disease, you always should proceed with a TE, and you can see severe mitral regurgitation, severely degenerated mitral bioprosthesis with FLEL leaflet. The mean gradient is 7, and you can see blunting of the systolic wave of the right upper pulmonary vein, prominent of diastolic, which goes with severe mitral regurgitation. This is a 3D image of the mitral bioprosthesis with a FLEL leaflet. As you can see, the posterior leaflet of the mitral prosthesis. And this is a true view, better image. You can see the valve, severe centric mitral regurgitation. And this is the orthomitral angle, which is 136, consistent with no evidence of obstruction of the LVOT if you put the valve in. That's what we have. Thank you very much.
Okay, thanks very much.
Degenerative mitral bioprosthesis, some MS, but mostly severe mitral regurgitation from FLEL, one of the leaflets.
Great, thank you, Stam. So now tell us, Stam, in terms of the TE, now you have the, tell us about this mini probe, because it looks like, now there's some advances on echo technology, right? So what's the difference between this new mini probe versus the standard probe, just for the audience?
I mean, the mini probe, of course, is you can put it in patients that there is problem with placing the probe down. So basically, if you have any difficulty or the patient has history of stenosis and has dilatation in the past, this probe is easier to place in. Some of the problems with the probe is that the 3D images are not as good as with the regular probe. So that's the downside. But still, as you can see, we can get excellent images. And so in some cases, less than...
It's about half size, right? What's the
half size. It's like a finger, like the small finger.
That's
so it's very, very small,
So for the audience out there, I think that's important to note. There's also advances in imaging technology, not just valve and device technology. So thank you, Stam. So let me just keep going here, or just fast forward on the, look at the CT analysis, which of course is very important in terms of valve-in-valve. So everyone, I'm sure, knows about the ViV Bypass Mitral Valve-in-Valve app, but this is the CT. You can see the axial diameter and dimensions, annulus area and perimeter is pretty similar of what I expect for 31 pericardial Carpentier pericardial valve prosthesis. And you can see that on the what we call free chamber view, right? That you have these kind of simulated where the SAPIEN-3 will be entered, and Stam set the aortic mitral angles on 136. We got 124, so pretty close. You can see the outflow of the valve is roughly going to be around 5.5 millimeter from the septum. Remember, this patient has a hyperdynamic LV, so we have to be mindful of potential LVOT gradient afterwards, but looks like it should be fine for, based on echo. So here's the LVOT area. We actually got about 200 millimeters square. People ask, well, what's the cutoff? I mean, I think people are still figuring that out. In the original Myra Guerrero's paper on valve in MAC, it was on 170. And with Jafar Khan and others talking about Lampoon procedure, their cutoff is more like 200. So this one is around 200. But of course, we know that you have to put the virtual valve in properly. So you can see on the right side of the screen that you need to put that gray cylinder at the outflow of the surgical valve. So if you put that cylinder a little bit more ventricular or deeper, it's going to be false, because that cylinder will artificially make your neo LVOT area smaller. Versus if you put that cylinder higher, the problem is that the surgical valve leaflets are all the way to the commercial post for the pericardial valve. So you're going to artificially make the neo LVOT area bigger. So you have to put the cylinder flush right at the outflow of the surgical valve, especially a pericardial valve. Now, in a porcine valve, such as Hancock 2 or Mosaic or Epic, it's going to be less obstruction because the porcine valve is shorter when the leaf is open. But I encourage you to go to the valve-in-valve app, which is what you see here now. Looking at the stand ID is 31, which is the surgical valve label size. The true ID is 28.5. And this is roughly how we're going to implant the valve. You want the valve to be more ventricular than atrial because you worry about embolization migration, but you also want the valve flare out. So if you look at the right side of the image, the sample on the bench, look at the leaflet, the yellow kind of surgical valve leaflet, it goes all the way down to the commercial post. So you have to be mindful when you look at the LVOT obstruction, you have to calculate all the way down there. Okay, so I'll let Dr. Sharma talk about a summary.
So basically, the transthoracic echo earlier showed more stenosis than regurgitation. But today they're saying more regurgitation.
Yes,
Although there was a question when I spoke to Akshat that he was showing that there was some the leaflet flail. It looked like more MR, but we went through the report so far. They kept on saying the gradient of 16 versus 10 mean, and it's a more stenosis, but turns out to be more MR. But that's okay. I mean, patient has a mixed mitral valve degenerative disease, which is common in these patients when they come back after this much time. And idea there is, we are going to put a valve-in-valve TMVR using SAPIEN-3 29 millimeter Ultra Resilia. Yep. With that note, I think we are ready to start.
Okay, Stam, you've shown
Go to
the
fluoro now.
steps for the
Oh, sorry.
transeptal.
Sorry.
Can you-
Yeah, sorry. Show the next slide. You're right. So before we go on TMVR next, we can show just one slide next. Yeah. The steps of TMVR, which they have corrected. Maybe Parasuram, you can just quickly go over for our audience, which has been available in March 2021 also, and many others, but we want to go again with the steps now.
Sure, Dr. Sharma. So we get a arterial and the venous access on the left groin, and we put a TVP through the left groin
After
femoral vein,
this,
and then we
put out
place a
slides.
pigtail, not essentially in the left ventricle, but in the aorta, so that when we go into the left atrium from the right side, we have an invasive LV-LA gradient. And then we get access in our right femoral vein, and we do our pre-closes, 8 French dilatation system, and then we do our transeptal. Once our transeptal is done, we use actually both fluoroscopy, especially we have the luxury of a mitral valve prosthesis, so we go to a RAO view to try to understand there is no parallax or minimal parallax, and understand the height of our transeptal, and also the measurement of the depth. And we correlate along with the TE as well on a bicaval explain view. And once we get the transeptal, our ideal transeptal is posterior inferior thick, about 3.5 centimeters from the mitral valve annulus. It's a little shorter than our tier, because that's we want to make sure there's not a lot of runway for us to navigate through for the SAPIEN valve system. At the same time, we want enough space as well so that the transcatheter balloon system is actually completely on the left side and not like interacting with the septum. And once we actually get the transeptal, we put the Safari in, and then we take our transeptal system out. We put the E sheath, and then we put a Agilis sheath over there. And the tip of the Agilis sheath is actually on the left side. And from there, we're going to show you now. We have a multi-purpose to go in. And then we direct the Agilis sheath to help us cross the mitral valve. We also use fluoroscopy, the same RAO view, to take the parallax off to understand. And we use TE to see how the trajectory, because it's a 3-dimensional thing and it'll be hard to see only by the 2-dimensional thing. And once we cross, we depending on the mechanism, we cross either with a J wire or a stiff wire, depending on the stenosis or regurgitant predominant mechanism. And then we put in our exchange length pigtail, and then we put in our Safari. And then we balloon both the valve and the septum to help us deliver the system, especially through the septum. And our balloons of choice is 14 or 16, depending on the valve type and the valve size. And then we go up with the balloon. We go up with the valve. Yeah, that's basically it.
Okay, so now Anu, you want to emphasize there are various techniques of the septal puncture. Radio frequency, classical broken burrow, then you have some other fancy device with a balloon. So which one is preferred? Anything preference, one for the other, both effectiveness as well as the cost?
Yeah, I mean, when we first started, of course, we used to use the broken burrow needle, but now, since the septal puncture has to be precise, radio frequency, we have been using radio frequency all the time. In very tough cases where they have pacemaker leads, so you will have 2 to 3 pacemaker leads, which could be the right atrium, left atrium, CS lead. That's the time we use the safe cross, the one that uses have the balloon, which is very good in that situation. So going back to the point which Parasuram made, if you can show the fluoro, oh yes, yeah. So if you see there, other thing you can do is you see the previous prosthetic valve. So the entire one length of the prosthetic valve, you have to give that much gap. And you have to be just at the base in the RAO view of the valve. That's also fluoroscopy guidance to say your trajectory of the movement of the SAPIEN valve will be ideal for if you do the transeptal at this particular point. So we have done the transeptal, and we have right now the Agilis and the wire there. So what we will do, we'll go with the multi-purpose and get into the LV. ACT now just above 300,
Yeah,
right?
Yeah,
Yeah.
you're close to 100.
So you see that? You need edgeless, that's moving nicely
You explain.
and on view, right?
So Stan, can you show us 3D?
Yeah.
Explain. Yeah. Explain. Put it on the leaflet. Put it on the.
Can we use the pigtail? You can use pigtail, but we always like to use the multi-purpose. It's there.
See single view. Single view.
You want to get us a J wire
Yeah,
rather
there
than
you go.
Yeah.
yes.
I'll take the.
So
Safari.
take this
So you can mag in.
Safari out, and then we are going to use the J wire. Since we said more of
Exchange.
regurgitation rather than stenosis, we will just go with the regular J wire.
Stan, can you show us a 3D, please?
Really, yeah.
Okay,
Okay,
so
so
we are
to
in the
cross.
LV, you see that? So if you have positioned your edgeless
Okay.
and
Mag in.
your multi-purpose in the right spot,
Turn it. Yeah, yeah.
easy
yeah.
to cross.
Okay. Up.
Now we are going into the LV here. Okay, so now we will
Give it
get your
give the view,
Safari
give the view.
again, bring it back,
Take the
right?
view.
Pigtail.
Pigtail. Okay, now what is the
J wire and pigtail.
300 wire, right?
Yes. Exchange.
So we need exchange length wire because we are going to change to long pigtail. Why we need the long pigtail? So when you place the Safari, it is positioned in the LV.
You put the
Facing
dual,
upwards,
no.
So long pigtail means what is the length of the pigtail?
See from the ventricle. No. That one.
30.
130.
White next
Okay.
to the.
Compared to usual 110?
Yeah.
On the thing.
Okay.
No. The double. To see from the ventricle.
Okay, now you can bring the Safari. You see that? Right.
Good. You can give
Put
it invasive LVLA. Or,
You want?
Please
Oh, that's
explain.
fine.
Explain.
Yeah.
We never had, right?
we have
I mean, at this
can-
stage,
connect-
if
we
you
can
want,
connect-
we can get the
we can
invasive
connect, yeah.
measurements if anybody wants. Otherwise, we can just proceed.
Okay.
proceed.
I mean, it's a less of an important because you are talking about more regurgitation. So even if there is a no stenosis, the valve is degenerated, has caused pulmonary hypertension, regurgitation and stenosis both combined. It's okay to just proceed.
There's
Okay.
two things.
Very nice.
We had a great one
Okay.
before.
Now, when we are coming out, you see that pigtail is coming out. I'm going to undo this and
wait.
we'll start coming out here also. Wait. Let me come out with this.
Let's just
You want to take the pigtail out?
get this first.
Give it there. Give it there.
Pigtail is out, and then we'll take the Safari.
Balloon is ready?
Yeah.
Give it there.
So we had a question
put the- yeah.
from the audience.
You should
It's
only watch
regarding the fact that this patient had instability with the previous anesthesia, and if that changed in somehow the approach for this case. In
Yeah,
other
very
words,
good
if the-
point. Very good point, and
Balloon first,
particularly
balloon first.
Dr. Morgan Montgomery is anesthetist now. Anesthesia, maybe we can hear. I know she may not have the mic, but what was the difference? Clearly, we know that anybody goes for surgery is more of a deep induction. But question is, did we do anything different in terms of inducing this patient who went for surgery and got into trouble at that time, became hypotensive and pulmonary hypertension? Anything different you did today?
Disconnect. This.
Okay.
Hang on.
Low GA. So same. So low GA. Another question is, you are right. I mean, maybe we can take the vote that do we need a TE in every case, or they can be done with the ice and without doing a TE. That's another point. In these kind of cases, still will require some degree of conscious sedation, just like superficial sedation being done in
Can
this
we show
particular
the
case.
septum?
The patient remained
Go-
okay. Yeah.
Septum.
Yes.
With echo.
Go up.
Yeah. We're ballooning the septum now.
Oh, okay.
Okay, down.
You need to go more.
Yeah, I'm going in.
Explain. Yeah.
Okay,
Yeah,
good.
now.
Now go up with the septum.
So what size balloon that is, and what is the choice?
This was 40 in
Go. Good.
the length,
Take it. Take it.
40.
So what about 12 versus 14? There is a question that people
No,
talk
it was
about.
14 versus 12 versus 16
14
because
versus
this is a
16.
29 plus.
Yeah. For 23 and 26, we
20,
use
yeah.
14, and 29 we use 16. But 16 sometimes could be traumatic to the septum.
Yeah.
So, yeah.
But we don't use 12 now.
No.
It's only 14 or 16. Okay.
Yeah, yeah. We've always been 14. Now this also, see that you have inflated, right? So we can just see. So look at this. This tells us the trajectory will be good.
Yeah. Okay,
Already,
explain.
okay. Coming back.
No, 3D zoom. 3D zoom.
Come back out.
Put it in the middle.
Okay.
Put the X-ray in the middle. Yeah. Okay. Okay. Zoom.
Now we
3D
will
zoom.
take out the
Okay, put it in the
Agilus
center.
after
Yeah.
this. The valve is ready.
Yep.
Skirt should be facing
Down.
up.
Come down. Wire.
Okay. Who is going where? You're there?
Person.
You, Parsuram.
Watch the wire.
Okay. Don't give it yes.
So what are you doing now? Keep.
Now we are taking the Agilus out.
Okay.
That's it.
The
So-
top camera. Yep.
There is nothing. Yes. Careful.
Mhm.
Good. The E sheath already is there.
Yeah.
Okay. So
You have wire?
Agilus is out.
You have wire?
Yes.
I have
Yes. Now we can go up.
Wipe.
And ACT
me-
around 300.
Yeah, close to 300. It was 280, so yeah, good.
Okay. So goal is 300. If you are low, give extra heparin.
So we check the skirt has to be atrial.
Yes.
Okay, so it's
Not ventricle.
very important. I don't know if they can,
Can you show the camera? Ceiling camera?
Yeah, they're doing it, showing it. Yeah.
Now come closer.
Yep, right there.
Yeah.
Yep. Good.
Atrial.
can
Normally
see.
when you are doing the tower, skirt is facing down.
Yeah.
So this is first and the second operator. Always check and double check.
Thank you.
And
Thank
we
you.
always make a rule that we announce it before it goes in the body. So Parasuram is going to
Don't worry,
announce
don't
it
worry.
again.
Yeah.
Thank you.
So it's very important also commander system faces down. So the E faces down. I don't know if you want, they want to show this
Yep.
as well. We can go ahead. You can
Okay.
put it in.
Orientation
Yep.
atrial.
Because when you flex, you're flexing the opposite direction, unlike aortic. And you can see the stiff wire, the Safari, the curve is pointing down, not up. So TAVR, you point up, TMVR, you point down. So he's coming.
Okay, go a little
Okay,
bit.
go.
Now the E sheath has to come out of the body a little bit, come down. Yeah.
Good,
So we can, yeah, it's okay. We have enough space. Yes, yes,
Good.
Yeah.
yes.
good, okay.
Okay. Oriana, careful there. I'm moving the balloon back. Okay.
Mhm.
Good. Are we locked?
Yeah.
Keep advancing, keep advancing. Nice. Good.
And this is the very crucial point now.
Good, very nice.
Yeah.
Perfect.
Okay.
Okay, let me save that. Okay,
Okay, fluorosave.
yeah, okay, let me mark it. Okay, good.
Okay, we're going to mag in
Yeah,
and
oh, too much.
too
Sorry.
much. You did, I did.
Yeah, we both did.
Okay, good. Okay, hold
Okay,
the wire.
Yeah, I am holding the wire.
Want to show a little bit more.
Yeah. Okay, good. Okay, Stan, you want to go to 2D or MPR or to show us the position?
Yeah, Professor.
I'm going to go.
This
a
is
little
pretty
bit more.
good.
Flexing
You flex more?
I'm flexing a little bit more.
Yeah.
Okay, Prof.
So it
Explain.
becomes-
Looks good, right?
Yes.
All right, looking good.
Okay, so lower end has to be right. Lower end of the SAPIEN valve
Yeah.
should be at the lower end of the prosthetic valve.
So this is +2 already, correct?
Yeah.
Yeah. Okay.
So you want to test first?
We
Same
need a-
thing.
Okay. Fluoro.
We need a
bit deeper.
lot of energy here now.
Higher.
Okay, 180.
Lungs down.
Keep it on,
Try
keep it on,
Sine,
yeah.
good. Okay, Sine, try.
Keep it on the thing.
Okay, good. Lungs back up.
Okay, off.
Okay. So very slow because it's not very coaxial. You can see that here.
Yeah.
Okay, good.
So we have to go very slow to lock it in. Otherwise, it's gonna be
Okay, 180.
lungs down, please.
Going up.
Hmm? No. Good. Nice.
Good.
So,
But
very
to make
nice.
sure it was in the right position.
Yep.
Take it this.
Okay. Back out, lungs back on. Very nice.
Okay.
Just
Off.
wait here.
Okay. Back up at 40.
Resuscitation, good.
Yeah.
Good. Let the patient
I think we
recover.
should do it
Looks
once
great.
more.
Yeah.
No, in your handout you had 2 dilatation.
Double tap.
I know.
Even without adding any more. Question is, do you need to add anything or with same amount? One more cc, right? Yeah. Add 1 more cc. Yeah.
Morgan, blood pressure.
Yeah. Yeah, it's coming
Okay,
up.
all right.
Give it there.
They can show the hemodynamic on one side also.
This side or this side?
It's always good to show hemodynamic in our valve cases.
Balloon.
Yeah.
Good. Beautiful.
Okay.
Okay, do 1 more. Go.
Okay. Fluoro, please.
Okay.
Flexing, doctor.
Yeah, I'm flexing. Okay, good.
Yeah.
Go back. Okay.
Okay.
180 again. We've added 1 more.
Yeah.
How many cc there? Atmosphere 6, 8?
Plus 3. So
Take it.
No, atmosphere on the
No,
syringe.
there's
Nothing.
no
Only
atmosphere.
9, they don't have atmospheres.
Just go all the way.
Yes.
Oh,
Okay.
Okay.
back out.
Keep it up, keep it up.
We need the pigtail back.
Yep.
Slow. Stamp.
Yes,
Looks
sir.
good.
Yes, looks good. Yes, put some color, bro.
And people have done it in case you have trouble advancing this valve, sapien valve across the prior valve because of that angulation,
Take it off.
that you can, through the left ventricle, you can anchor the wire. And then we'll give you that rail in order able to advance this tower valve. I mean, it's basically tower valve, but
Good.
Is there the wire is in, still wire?
Yes, there's the
Yes,
wire
yes.
still.
So it's
Stan, we're going to
minimal.
exchange for
Yeah.
pigtail. Just 1 moment, please.
Yeah, minimal MR. Most likely from the wire. Where the wire is, no PVL. Great result. Let's measure gradient. Okay. Measure it. Measure gradient, bro. Okay. How much? 3, mean gradient of 3 through the valve.
Good.
Okay, push LVOT gradient. LVOT, no, it's not LVOT. Prof, the LVOT is there. Prof, come on, man. There, yeah, come on. Continuous Doppler.
what happened?
All right. Let's look at the gradient.
Measure. Yeah.
Let's look at the gradient.
Yeah, that's the LVOT. So 13, peak gradient 13.
Good.
No LVOT obstruction.
Big gradient 13?
How can it be 13?
LVOT.
Ah.
No,
LVOT
the
gradient.
But what is the
gradient
gradient?
through the LVOT.
Mean,
LVOT.
Mean
3.
Yeah, mitral
3.
gradient is
Oh,
three.
I had 13.
Yeah, I heard 13
No,
also.
13 is the LVOT gradient.
Oh,
LVOT.
LVOT gradient.
Peak LVOT gradient is 13. Mean gradient prosthetic is 3.
Good. That's good.
Okay. That's
I mean,
it.
this is the valve being used now for the
Get the
valve in
valve.
valve TMVR in America. About 800
Then
cases
bring
are
this
done,
into the
Regular
atrium and then
you know,
bring this
per
into
month.
LVEF
So
and
about
LVEF.
8,000, 9,000 per year are done the TMVR valve in valve using the SAPIEN valve. No other valve is available out of USA. Is the my valve is used for this purpose also. You can only use the balloon expandable.
PVL.
Okay, we are not doing any gradients. You're coming out, okay?
Yeah,
Come
that's
to
fine.
LA, and then we can go.
Okay, good.
So shall we look at the ASD, Stan?
Yeah, we'll see. Yeah.
Okay. I'll take the wire out. Oh, you want the wire.
No problem. Come on. Okay, let's go. Yeah. Let's finish up here. Let's finish.
The hemodynamics are good, saturation is good. Even if you create a small ASD, about 10% of the ASDs are closed. Parasuram, you tell us, you are our ASD guru. Which case would you close it?
Sure, Dr. Sharma. So in the past, we usually had a low threshold to close if someone actually had pre-existing right ventricular failure, at least severe, and at least moderate to severe TR. But now from our experience and also from other published single center data, we know that most of these ASDs are actually small enough, which is less than 10 millimeters. They usually close by themselves at 30 days. Okay. We still evaluate them with the transthoracic echo at 30 days, and depending on how the size of the ASD is and how the right ventricular function is and how the TR is, we make a decision at that time. We no more do at the same time closure of ASD unless it's Apollo or very big subtostomy that we need to do to deliver the system.
Okay. In Apollo, every case we are closing it, correct?
Yeah, there's less people closing it now, I think, because it's harder to go in as you go back in. But this patient has very bad RV dysfunction, so we should follow up at 30 days just to make sure. Because if any sign that the RV is getting worse, we should close it. So.
Okay.
What does it look like echocardiography-wise?
Sam, what do you think the ASD?
It's left.
Can be left.
Left to right, as you can see, left to right.
Yeah. How big is it?
Well, if you take the catheter, because it's a catheter still in.
No, catheter is out.
No, we have the just J wire, just in
If
case.
you can take it out, I can measure it.
Take the wire out now.
Yeah, okay,
no,
fine.
please, take the wire out. Show the pure hemodynamics.
Yeah, okay,
Echo dynamics, not echo dynamics.
Okay.
Without the wire. Tell us.
Very small. Right?
Right there.
That's a very important reason also
To explain.
that, when we are doing transeptal,
Come on, man, come on, let's go. It's not the time to learn.
it's very important.
Please.
Transeptal as well as when you do the balloon dilation. We don't go more than 14 millimeter
Sorry,
balloon.
man.
Yeah. So 14 is preferred, and 16 we call more hold, and 12 was the trouble. We used to use 12 in the past, but no. 14 is the ideal one. Even if the bigger valve, just go few extra for few extra
Because of
seconds.
the recoil,
Yeah.
right?
Recoil, yeah.
Yeah. So one thing for the audience is that Dr. King, Dr. Sharma mentioned, you don't want the valve to get stuck in the atrium,
That's right.
septum. That is the worst situation. And because remember, the valve is not protected, right? It's not like the self-expanding valve. So you can actually get jammed in there, and then you'll be problem crossing, and then you will not be have to troubleshoot. So
1.2 by 6.
yeah, okay,
1.2 by 6 is the.
Very good.
Okay.
That's what it was, our balloon anyway.
yeah.
The ASD, yeah.
Okay.
I just want to, Dr. Sharma, to tell a little bit about why the discrepancy for the mitral valve. We thought it was mild to moderate MR, but that was through transthoracic, and transthoracic, we look the MR is in the back, and it's a lot of reverberation artifact. That's why if you suspect MR, especially on this patient, you should do a TE. While on the transophageal echo, you see the MR coming straight on you.
Yeah.
And so that's why it was the difference. And the gradient, the valve is destroyed. One of the leaflets is it's flel, so definitely degenerated mostly with MR. So there was.
Actually, I can tell you this. Our fellow Akshat, he pointed out that because when I was making the slide, I was just going with the point. Is patient did not have TE echo here. Was supposed to get at the time of anesthesia, but patient crashed, so TE was not done. So goal was to do TE today, but. Apparently in the echo, again, the existing echo, there was some flail leaflet, but we just went with the, what was the recording was. Recording was mild to moderate MR and MS. So basically, but anyway, so key is the end results is fantastic now. There's no regurgitation, no gradient. Minimal 3 is normal. As you know, less than 4, we call it normal. And Pedro, any question from our audience before I go to my lecture?
Yeah, we have a comment from Dr. Saibi in Colombia who is congratulating the team. He says the procedure was very simple and the meticulous protocol make it simpler than what sometimes the procedure is. So this is great. Thank you so much for the comment. Yeah.
Now that's why we showed the step, how to do it, and we showed those step by step again. Yes, always. That's what I think we always try to teach also.
And that's our goal is
have
that,
the same steps. Same steps.
Same steps that you go back. And so many people, we get an interview, I go various countries and people come and say that they, for many things, they went ahead, look into our case presentation and what the trouble was, they followed and so forth. So this is whole the purpose of our educational is. And that is what I say also. Just like once you know
Stem
your
TE,
stuff,
please.
Take it out.
Yeah, just a minute.
or your complex cases become simple, particularly by using rotational atherectomy. So key is that once you
Okay,
know
go
your
ahead, Sam.
stuff,
Thank you.
complexity goes down. So with that note, I think if it's okay, guys, less noise now,
Yes.
and let's go to the presentation now.
Take
Yeah.
sandwich,
Okay. So our goal today is
Coming back.
yeah. So basically, the recent publication in the field of TMVR and MTR. One, I'm going to talk about the two trials, Reshape Heart Failure 2, Matterhorn, and then Choice MI trial, which is for the mild versus moderate to severe MEC. Then valve-in-valve tower, TMVR versus reduced SMVR in the bio-prosthetic mitral valve degeneration, and some data on the newer TMVR devices, Tendyne, Intrepid, and Saturn. So first one is Reshape Heart Failure 2. It is kind of our co-op trial done well. Compared to the Mitra, and remember the Mitra FR trial was not did come out good. So key is that anytime you take care of the functional mitral regurg, you have to have good medical therapy. This trial done from Germany, the kind of a co-op trial redone with a 2-year follow-up, allocated to device versus allocated to control group. Only thing is, since now the device is clinically approved, in refractory cases, almost in about 15%, they did the clip in the control group. See, 38 of the 255 require unplanned tear, so they still remain intention to treat and follow up for 24 months. The individual individual point severe mitral regurgitations were not different. Basically showed the similar data: the decrease in heart failure hospitalization, decrease in mortality, and overall excellent outcome of the mitral tear in these patients with a functional mitral regurg, where guideline directed medical therapy was there, but not very strict. Co-op trial had a very strict, so question always comes. You start the guideline directed medical therapy, and that's a real life. And I'll ask Anu, involved in many of those cases. The patient don't tolerate. And by the time their months goes by, their LV start deteriorating, and we have cases, while 6 months they decided heart failure team, guideline directed medical therapy, EF was 40%, now 6 months later is 20%. So question always comes, when you have seen the mitral clip improves survival, decrease rehospitalization, why we had to be that aggressive? I know I'm not saying we go against the guideline medical therapy, but I think it should be start and think mitral clip very early in the game. So Anu, you want to make a comment on it? Little drastic statement, but I'm just saying, let anybody question me, knowing that trial after trial for FMR, heart failure presentation, not asymptomatic, heart failure presentation, class 3 and 4, they start guideline mitral therapy, they keep adjusting, and we, in our own center, we have a handful of cases where EF has gone down by half. By the time you figure out your GDMT, patient doesn't come, doesn't get this appointment, this and that. Should you really wait for the full maximization, or start and think about the clip soon? So I think this is a part of the good discussion.
Yeah, so the EF is, I think, important. So when you're less than 30, we know when what they're calling it as a burnt out LV, probably nothing works. That maybe you can think, go directly to clip. But like you mentioned, in a drastic statement, it was a drastic statement, in the sense that some kind of therapy has to happen. And we have seen it when we were part of the co-op trial. When medical therapy was started, they come back to see us. Many times the MR was better, and moderate to severe became mild to moderate, and then we were not, the patients were not going into that. The question is compliance and follow-up of these patients. So there's no need to probably wait for 6 months, but start therapy, see them in between 4 to 6 weeks. At that time, make the decision. But I think some therapy has to be there. Very important also is, just because you did the clip, because now they are into the thing, just because people don't like to take medications, and especially diuretics and all that. These are reasonably elderly patients. They say even if they want to have a quality of life, they take diuretic, that they cannot go out of the house and all these things. So these medications have to be continued, maybe at a lower dose, even in the post.
Okay, Very good point. So, Parusam, you want to make any comment on medical therapy of heart failure patient and when to think about the mitral clip or MTR?
Sure, Dr. Sharma. I second your thought and Dr. Kinney's thought too. Aggressive medical therapy and aggressive referral for heart team evaluation is key, because we know that even if patients get referred to us, sometimes the MR gets proportionate, meaning that left ventricle is so burnt out that you're going to expect some amount of MR. And we know that from the coapt, those part of the arm doesn't do well even with the edge-to-edge repair. So that's the reason why we want to be aggressive, put these patients on whatever maximally tolerated medical therapy they can, but at the same time, have a very close follow-up so that the LV is not burnt out, and by the time they come to us, it becomes more of a proportionate MR rather than a disproportionate MR, because we get more yield when we do edge-to-edge repair in disproportionate MR.
Beautiful. So I think that's the way, and clearly the heart failure symptoms improvement and very good for the MTR group. Second one, again, very provocative. So what if now we get MTR against the mitral valve repair, but it's for functional mitral regurg. Now people say, surgeons clearly said, and I'll ask Gilbert to comment on it, say it was a wrong trial. Why? Because we don't do the surgery for the functional mitral regurg. But this German guys are very bold enough. They did the trial, MTR against mitral valve repair surgery in secondary MR. Gilbert, comment on that word?
Yeah, this was a trial that was spent many years to enroll. I still remember the first time was like, 5-6 years ago. It's just that, the clock is ticking against, approval of devices, right? So mitral clip was approved for secondary arm in Europe, right? Well, before US, so it was very hard to enroll in this trial, but they did. And you will show the results. I think essentially, basically, with one-to-one randomization, it's a small trial, not a big trial, but it's very hard to convince patients to be randomized surgery versus mitral clip at that time or MTR, because obviously the safety differences. So, but you can see the paper, the findings are essentially equivalent in terms of the two therapies.
But only question is which case? Knowing that many of the trials of the functional mitral regurg for the surgery have been negative, so which case would you send for surgery for FMR?
That's a great question. So the two situations, one is that they need concomitant surgery, whether it's revascularization, which is part of guidelines, or AFib, because we see a lot of atrial secondary MR. And fixing the MR may not help the AFib, and if you have AFib, it's still so surgeons can do AFib surgery during procedure. And of course, you can see here 10% also need tricuspid valve surgery.
Yeah.
So if you have severe MR and moderate severe TR, we've been very aggressive about fixing the TR as well. So those may be considered. Of course, now in the context, you also have transcatheter tricuspid therapy. So now the decision will be what kind of surgical risk is the patient.
The second point, I know at Sinai with Dr. Adams, the leader for mitral valve repair, where it's 99%, 28% had a replacement. Is it common for the FMR? I know primary will be very high.
Yeah, remember the New England Journal trial. The first New England trial, repair had a very bad durability.
Yep.
And I think because a lot of these patients have, like you said, burnout LV, so it's better to replace the valve than a bad repair and they come back, because the options are very limited. So that's why you have this kind of proportion.
Okay.
Yeah.
Beautiful. Okay. So just to say, we said outcomes were fine, kind of favored in the 1 year with a tier group, but except one, mitral valve reintervention was 5%. Others used to LVEF implantation, stroke were identical, but only one negative was mitral valve reintervention in the MTR group. And as far as the functional class, 5-minute walk distance were identical between both the studies. So then the third, so now this field is exploding because of the every data of the MTR plus. So let's go to like just same thing when interventionalists did. Then let's go against left main with the cabbage, the PCI against cabbage. The same thing, we are in that kind of the tier against the primary MR. And those are the three trials, will take about 2 to 5 years. But to answer that question, can there be a subgroup of patient age-wise or STS-wise, and there are no longer those burned out cases, not functional mitral regurg, but primary, the trial primary, the repair HR and repair, mitral HR and repair MR will show, and trials are ongoing, people are being randomized, and I know one of our investigator from Cedars-Sinai is the lead of the primary trials, and so this will answer the question that can selected cases up to some degree of follow-up, whether it should be a 2 or 5 year follow-up, and what are the primary endpoint. They think less than 2 plus mitral regurg is still a good success, which may not be a true, but whatever it is. But key is this field is going forward with 3 randomized trial, which will answer in next few years. Then question comes, what about various devices which we have at present based on the calcification of the valve, MAC, but same valve-in-valve TMVR, and you see the most of them, transcatheter mitral valve replacement with the various devices, particularly mild calcium or moderate to severe calcium. This is called choice MI, but it is for the mitral valve and various devices. 8 different devices have been tried and basically showing that you have no calcium versus you have severe calcium. But I thought that we don't do the TMVR unless it's a severe calcium.
Yeah, so this is the native device.
Yeah.
This is not the
Native,
balloon
yeah.
expandable device. So there are some situations like the Tendyne was published. We have, the Apollo had the MAC-M as well, because not every anatomy fits the SAPIEN. Most of these are too big. So that's why they need these dedicated device for this registry. So
overall, basically showed that if you have severe calcium, your outcomes are a little lower compared to if you have mild calcium. But yes, in selected cases can be done, and this is basically showing on the left side the mild calcium, right side moderate to severe calcium, although your mortality at 2-year follow-up was not different, but overall the mild calcium has a less trouble expected, less bleeding, less kidney injury and compared to the severe calcium. Then the third is comparing valve-in-valve meta-analysis, like case which we did, valve-in-valve TMVR versus reduced surgical mitral valve. Published International Journal of Cardiology, overall 11 trials were included and basically showed 30-day, 1-year mortality identical in the valve-in-valve TMVR. Most of them are in favor, less acute kidney injury, less bleeding, except the LVOT obstruction was higher and also higher incidence of paravalvular leakage with the TMVR compared to surgical MVR. So expected, so I know this field is important, though basically showed that up to 3-year data we have, valve-in-valve TMVR in the registry data compared to surgical mitral valve replacement, no difference except more paravalvular leak, but clearly the less event with the acute kidney injury. So this field, as there's no randomized trial at this time. There are the trials which have been done in the past and have subsequent follow-up. So if you take a mitral clip only, there is basically is negative. So once you go to the registry data of the TMTR versus surgical valve repair, overall pooled analysis showed higher mortality with the mitral valve repair, and there clearly we know redo surgery. So I think ideally is that if patient needs the surgical valve, your clip is not the answer, but again, it all depends on subsequently what we'll have from the trials. And so with that note, the last one is the Tendyne is the valve which is the transapical, which have been approved in England. I mean in Europe has been approved with the CE mark approval. You still have the trials have been done. Overall, it's a little complex device. Apical, we had 2-year follow-up about 100 patients, about 40% mortality at 2 years, probably expected in these patients. Whether it will get approval, symptomatic improvement and all that happens with the valve. So it may be, if at all, it is a transapical, whether it will see the light in the United States with the FDA, because many of these cases, of the 200, about 90 plus cases were done in America. So about half of them. So Gilbert, what do you think about the Tendyne?
Yeah, so the Tendyne, the Summit trial was supposed to randomize between Tendyne, TMVR versus mitral clip. That's been stopped.
Yeah.
So the only arm they submit to the FDA is the MAC.
Yeah.
So they might have get approval for MAC, but it is transapical. That's the issue.
Transapical and only the MAC.
Yeah, and so
which if at all will be.
That's right.
Then the another device which we are struggling, which we are part of, is the Intrepid trial, and this is actually overall for the TMVR trial. We have done few cases. They are coming with a smaller sheath size, as we talked about, still venous trouble, vascular problem because of the sheath size of the 30-40 French, transeptal, everybody requiring the ASD closure, and some advancement have been done with the 29 French, and maybe Gilbert can comment on it with the Apollo, this trial ongoing at present. Transeptal now. We are doing transeptal. Transapical we have not done for last 4+ years, only transeptal but very limited number.
Yeah, no, Transcatheter is definitely a game changer. You see the number here, 0 mortality at 1 year versus, Tendyne is 25%. So I think that is the biggest difference. There's less insult to the LV. I think the issue is screening, as we know, in terms of screening these patients in. And also, I think, the 29 French is going to be also better in terms of profile, but also there's no suture to remove. So it's simplify the procedure. So I think that is going to be an improvement. And so far, the early results have been promising.
But your timeline point of view for the Apollo, for the our interatrial, the transeptal device, what do you think when the trial could be completed?
So so they are trying to finish the first 200 patients this year. So okay. I think in the next few months. So that's why they are trying to ask us to get across the finish line. When it's be commercial, that's another question. Yeah. So that will usually take some time for follow up. But it's a single arm. It's not a randomized study.
Yeah, and then this actually we think the heart failure team is the gatekeeper. So we are having a big discussion with our heart failure team that how can we increase the width of patients being referred. There's another device called Saturn, which is the transapical delivery system, but I think it's outdated, although they were just recently published in thoracic surgery. Looks good, but I don't think these will have any role once you get the transeptal. So there's another one is the Alta valve, which is the tissue valve, basically again night node expanding, filling up the entire atrium. It doesn't immobilize. I mean, it does not mobilize and can be done transeptal or apically. I don't know much about it, although it was just published recently in Structural Heart Journal. Gilbert, do you have any comment?
Yeah, it's interesting. Now it's mostly transeptal. So the fixation is totally different. The Intrepid is based on the leaflet and the annulus. This one is just but atrium. Yep. So you have to size it properly, and there have been some reports of if you late tilting and movement because the atrium remodels and change. So it's not really, but the beauty of this device is that there's no LVOT obstruction risk, so the screen failure rate is very low. Yeah. So a lot of patients get screen accepted, but that's the point is that whether the fixation is going to be the important point.
And there are few other devices which, although nothing came out in 24, which is the latest one I did. So that two-step procedure. Yeah. Put the ring first and the mitral, bring back patient, then replace the valve.
So Edwards has the SAPIEN-3. Yep. The trial is done, 500 patients. They're waiting for the results to be presented. Maybe a TCT this year. We'll see. That's a dock against a leaflet, then put a SAPIEN-3 in, like what we did today. Yeah. So the challenge of that system is how do you put the dock in securely against a native leaflet. The other one is called a high life, same thing. So high life is going from the aortic side. So aortic side putting like a dock, and then you put the valve transeptal. So it's two systems. So Stam, you've seen some of these devices. You want to comment on any of them?
Will take some time.
That's it. And let's see if they come to the finish line. Overall, initially they all look good, but then many of them bite the dust. Exactly. They start embolizing, thrombosis, and so on and so forth. This is the good pictures of this. So let's just complete it. We are right to the hour. Mitral clip in FMR to perform superior to guideline directed medical therapy in terms of reducing heart failure, hospitalization, and mortality. Follow up, hence mitral clip, and this is the one I wanted to say, should be considered early in the management of the symptomatic despite GDMT. And you see the aggressive word I put in the parenthesis because being involved in these cases, we have seen so much because of scheduling that patient comes back, you decided today with a severe MR, patient comes back 6 months later, is still symptomatic, and now the EF from 50 has become 30. So key is that be vigilant, more close follow-up. So GDMT is good, aggressive plus minus. I may be criticized for that word, but that's what the real life is. We have seen that. The small randomized clinical trial, we show that MTR with the surgical mitral valve repair has shown that good results, but the answer will be the primary MR trials, and then the issue of the meta-analysis of the valve-in-valve TMVR and SMVR has been okay, but the MTR data are not good. And the field of new TMVR devices for native mitral valve disease is ongoing with mixed results, and overall success of these devices still remains far away from becoming approved for clinical use, despite 10 years of in the 10 years of this trial.
So, says before you go into the questions, we have
Yeah.
a couple of late questions.
Good.
First, if you worry anything about the amount of the valve in the atrium size, if there is a risk for thrombosis there,
In
the valve in
atrial
valve, yeah.
Yeah,
In
the valve
atrial,
in valve. Yeah, so we like to anticoagulate this patient at least 3 months, just like a surgical bio-prosthetic valve. So we like to put them on either the DOAC or warfarin, depending on what they're already on. Most of them are on some kind of anticoagulation already for 3 months to avoid that.
great.
to
Second
your-
question is about the paravalvular leak in very calcific valve in valve.
Yeah, so valve in MAC is more of a problem. Valve in valve, because you have a circle, usually is less a problem. But good point, Dr. Moreno, is that valve in ring.
Yeah.
So valve in ring, because some of these rings are oval or D-shaped, when you try to put a circle in there, it can lead to paravalvular leak. So that can be a potential problem. So you're right. Usually seen in valve in MAC and valve in ring, but not valve in valve usually.
And
Now-
both of those trials, mitral trials, have shown that valve in ring and valve in MAC is bad outcome compared to valve in valve, is all because of the residual moderate to severe MR.
Wonderful.
Yeah.
Now, the major complication, just few questions, major complication that should be aware for this procedure.
Embolization.
Yeah.
That's-
Embolization.
Yeah.
And finally is
ventricular or atrial.
Yeah.
Yeah, ventricular.
Wonderful.
Yeah, those are the two things. Yes.
embolization, big deal. Yeah, in ventricular, you need to go to the OR, and the aorta is another complex. The final question is regarding, do you need hemodynamic confirmation or just with the Doppler is good enough for the success?
Just like showed it.
Echo is good.
Yeah,
Echo is good.
Echo is very
Echo
good.
is good.
It's-
Very good point, sir. So, those who are believer of the hemodynamics, I
Yeah,
may
you
be
can do
one
it.
of the last men surviving, but I've been booted out. I would have put the hemodynamics, and this is echo is good enough. And I think rightly so. Least you do into these, better they are. So very good point. So let's come to the reshape heart failure trial with not true. More than 98% in the MTR group got the mitral clip. Overall, less than 1% patient, the control arm group got the MTR. Readmission for heart failure and mortality was significantly lower. Higher number of patients remained in NYHA class 1 and 2 in MTR group. Clearly, overall, not 1%, about 15% in the MTR group got the clip. The trial comparing MTR versus surgical, Matterhorn showed the following, except all-cause death was similar between two groups. Rehospitalization trended to be lower in the MTR group. Mitral valve reintervention was similar in two groups, and LVEF implantation was similar in two groups. So wrong is the mitral valve reintervention was not similar, was higher in the mitral MTR group. Third one, following are the ongoing trials comparing MTR versus surgical mitral valve repair, except primary trial, Transcend trial, mitral heart trial, and repair MR. Clearly, Transcend was the trial of the tricuspid evoke. Thank you very much. This way we complete our presentation, and thanks for all our audience questions and making very interactive.
Yeah, thank you so much for the wonderful example today for the heart team. And we do these meetings every second Tuesday at 9 a.m. The next one will be March 11 at this time. Thank you so much.